For generations, doctors have been taught that the first-line treatment for all Black patients that have hypertension or high blood pressure is a different medication than all other races. But as of August 2025, that's finally changed. My name is Dr. Joel, the Medical Mythbuster, and today let's talk about hypertension and race-based prescribing. For the past 2 decades, US hypertension guidelines have told doctors like myself that Black patients without other comorbidities should start with only 2 medication classes: calcium channel blockers or thiazide diuretics, instead of ACE inhibitors or ARBs, which were first line for everyone else. But in August 2025, the American College of Cardiology and American Heart Association released updated high blood pressure guidelines that no longer uses race in initial treatment decisions. Instead, they recommend choosing from any of the 4 first-line blood pressure medication classes that I mentioned earlier, and basing that decision on a person's cardiovascular risk, using something called PREVENT. The PREVENT calculator estimates a person's 10 and 30-year cardiovascular risk. That's things like heart attacks, heart failure, and stroke. And it does that by looking at your individual factors, like your cholesterol, kidney functioning, smoking status, diabetes, and more. In other words, treatment is based on a person's actual risk profile, not just their race. And this shift matters. Research from UCSF showed that even when doctors followed the old race-based prescribing rules, Black patients still were more likely to have uncontrolled hypertension than non-Black patients. That meant using race-based prescribing wasn't working. Instead, it was medication adherence, lifestyle and diet, adding a second or third drug that actually made a difference. Other studies, like this one, show that Black people aren't a monolith, and that hypertension patterns differ among people of African descent depending on geography, environment, access to care, and so much more. Race is not a proxy for biology. These new guidelines are huge because it moves us away from race as a shortcut for pharmacologic therapy. When we stop relying on race and instead understand why a disease process happens, we open the door to better, more precise care for everyone.